Good evening and a warm welcome to everyone joining us this evening. New insights into management of progressive NAFLD, the role of the physician. A session that's organized by the Sri Lanka College of Internal Medicine. And to moderate this session, this interesting session this evening, is Dr. Krishantha Jayasekera, consultant physician, teaching hospital, Karapitiya. Dr. Krishantha, good evening and over to you, sir.
Good evening. SLCIM monthly webinar sponsored by Dr. Reddy's Laboratories. During the peak of COVID-19 pandemic, in addition to clinical commitment, SLCIM conducted many academic activities via electronic media to its membership and the public. There was an immense enthusiasm among the membership, and which prompted the president, Professor Tilak Jayalath, and its exco to continue these webinars outside COVID. One such was the previous webinar on emerging epidemic of leptospirosis. And I would like to thank all the resource personnel and the moderator for making it a success. SLCIM decided to proceed further with webinars on non-communicable diseases as well. One such is a new insight into the management of progressive NAFLD, the role of the physician. NAFLD has become a major problem for practicing physicians as part of a systemic illness or on a routine ultrasound scan of asymptomatic patients. Today, we have Professor Anuradha Dassanayake, who will update us on this all-important topic. Just to introduce Professor Anuradha Dassanayake. Professor Anuradha Dassanayake is a consultant physician with an interest in liver diseases. He is attached to the Faculty of Medicine, University of Kelaniya. He received his overseas training at the Liver Centre at Royal Free Hospital, London. His research interests are on NAFLD and liver transplantation. He is a member of the North Colombo liver transplant team. He is an executive committee member of the South Asian Society for Study of the Liver, and he is in the Sri Lankan team lead for the ESL Global Survey on NAFLD. He regularly co-authors a chapter on tropical liver diseases for the Journal of Medicine, that's Medicine International. He has more than 60 publications in his peer-reviewed journals, mostly on NAFLD. In addition, he is a talented sportsman, we all know, who opened batting for the medical faculty cricket team, and he obtained university colours in table tennis as well. Professor Dassanayake will talk to us for 40 to 45 minutes, and he is happy to answer questions from the audience. You can text your questions to Q&A box in the bottom right of your screen, and even during the lecture. So over to you, Professor Dassanayake.
Thank you very much, Krishantha, for those kind words of introduction. First, I would like to thank Professor Tilak Jayalath for inviting me to give this talk on a topic which is very close to my heart. First, see what NAFLD is. NAFLD is a complicated metabolic liver illness, and the latest nomenclature is metabolic associated fatty liver disease, and it's a multi-system disease. How problem is NAFLD in Sri Lanka? It's a huge problem. 30% of adults in urban areas were having NAFLD in 2007. This is from our Ragama health study. And nearly 10 years later, it has doubled to 66%. So at Ragama, 66% of the middle-aged and elderly have NAFLD. And it's the most common cause for cirrhosis in the country, and the most common cause for referral for liver transplantation. It's these gene in our country, and it is the most common cause for hepatocellular carcinoma in Sri Lanka. So my talk today is on progressive NAFLD, and what is that? Progressive NAFLD is the which leads to fibrosis, cirrhosis, and hepatocellular carcinoma over many years. And I'm going to touch on both fibrosis, cirrhosis, and hepatocellular carcinoma associated with NAFLD tonight. And this accounts for about 10% of the total patients with NAFLD, and they can progress with even with normal liver enzymes to these endpoints. So what is non-progressive NAFLD? That is the common NAFLD we do see every day. NAFLD that does not progress to cirrhosis and hepatocellular carcinoma. There the liver mortality is insignificant, but the cardiovascular mortality is still very high. So is it safe to have non-progressive NAFLD? The answer is no, because the cardiovascular risk is and also other risks like malignancy risk also. Then the risk of dying from other illnesses of also high, like dengue, and they can't be liver donors. And also they find it difficult to obtain life insurance because they want the premium to be increased for insurance of their lives. So I'm going to discuss a patient, I'm going to discuss 2-3 patients tonight. So first patient, a 32-year-old obese mother of 2 young children with very poorly controlled diabetes, develops rapidly rising liver enzymes and high lactate levels during the late leaking phase of dengue while maintaining a reasonably good urine output. AST rose to 20,000 around day 6 and she succumbed to her illness with multi-organ failure on day 7. So this was a hyperacute liver failure in a patient with fatty liver, and this is probably because the fatty livers do not tolerate ischemia very well. It's very well known that if you have fatty liver, your prognosis during dengue is going to be less good compared to a person without fatty liver. So you start your fatty liver in your childhood, probably say following intake of large amounts of fast food, and over many decades you end up with cirrhosis and hepatocellular carcinoma. This is probably each step taking as many as 10 years to 15 years. So if you develop fatty liver as a child after taking fast food, you can end up with cirrhosis and hepatocellular carcinoma during your middle age, that's about around 50s and 60s. So what are the contributors for progressive NAFLD? Insulin resistance, lipotoxicity, and genetics, and gut dysbiosis or changes in the gut microbiome. So NAFLD is a multi-system disease as well. There is higher risk of diabetes, ischemic heart disease, CKD, hypertension, malignancy, polycystic ovarian, and even polycythemia. Majority of patients with NAFLD die of cardiovascular disease. What is the liver-related mortality? You see a liver-related mortality only in progressive NAFLD. The single most important predictor of liver mortality is the stage of fibrosis and not the degree of the elevation of transaminases. You can progress to cirrhosis sometimes even with normal transaminases. So what are the clinical predictors of fibrosis? Age. If you get a middle-aged man with diabetes, obese, and other component of the metabolic syndrome, think of progressive NAFLD. And they are although not in the guidelines, if there is a strong family history of cirrhosis and hepatocellular carcinoma, again, you have to suspect that he is probably having progressive NAFLD. What's the plight of these patients with progressive NAFLD? Very poor. Even in the United States, majority of them present with the complication of cirrhosis like hematemesis or hepatocellular carcinoma or ascites. then the prognosis is poor without the liver transplant. So how do you diagnose fibrosis? There are serological markers and imaging techniques to diagnose fibrosis, because we need to know whether there is fibrosis or not, because we want to intervene and try and reduce the progression of the fatty liver. So this is a fibroscan, a new kid in the block, which helps us to diagnose progressive NAFLD. And when you do the fibro scan, it's just like an ultrasound scan. It gives you two values. One is the amount of fat called the CAP score, and the liver stiffness in kilopascals. Now this report on the left hand side says that liver stiffness is 3.5. Be mindful of these values, and on the right hand side the liver stiffness is 33. I will tell you exactly where these values fits in the scale. This is like in a young child with absolutely pristine liver. When there's absolutely no fibrosis, the liver stiffness is around 2.53. When you grow older, when you have stiff liver, then when your fibrosis sets in, the value rises up to 7, 8. Then the latest cutoff for significant fibrosis is 8. So if you have liver stiffness measurements of more than 8 kilopascals, you diagnose advanced fibrosis. When that is about 12.5, you diagnose cirrhosis. A person who is dying of cirrhosis will have a liver stiffness measurements of about 75 kilopascal. So I am going to concentrate on these 8s, 9s, 10s, 11s, and 12s today in my talk on how we can intervene and prevent the progression into advanced fibrosis. The simple most way of doing is the FIB4 score. I have told you this earlier in my talk to the college. It's very simple. It won't cost you more than 1,000 rupees. Just take the age, the platelet count, the AST and the ALT values. Make sure that you do these from reliable labs, and they don't have any other cause like ITP or muscle disease or hemolysis to increase these values. And if you have these reports from a good lab, and this is very sensitive way of predicting fibrosis. So if it is less than 1.45, it is negative, and if it's more than 3.25, it is advanced fibrosis. This comes as a free app in a smartphone, and you can download it very easily. It won't take more than few seconds to get a bedside value. So I'll give you 4 examples here. Age of this the common patient that we see every day: age 30, ALT 80, AST 40, and the platelets normal. The FIB4 is 0.56. Absolutely safe as far as the fibrosis is concerned. Example 2, age 55, bad age, ALT is 60, and AST has started going up. The platelets have started dropping. The FIB4 is 2.17 and the dangerous range, and you need a fibroscan and then go on from there. This is example 3, very clear-cut cirrhosis patient. The FIB4 is 7.87, platelets have dropped, AST ALT has reversed, and the age is high risk. So this is a patient with cirrhosis. Just an example of a patient who has normal liver function, that's less than 40. See the ALT 24, AST 36, platelets 130. Even the FIB4 score is, age is high risk, FIB4 score is 3.39. So this is cirrhosis. So this very easy bedside test to say whether there is dangerous fibrosis. Yeah, so coming to therapeutics of NAFLD, what we are going to do with these patients with progressive NAFLD, there are 2 ways of treating them: non-pharmacological and pharmacological. And pharmacological therapy like vitamin E and obeticholic acid is considered only in progressive NAFLD. So there is absolutely no treatment options for patients with non-progressive NAFLD. At the same time, you have to think of treatment of the other common risk factors present in these patients. So why do we get NAFLD? It's food related. Probably the biggest ever food poisoning. It is energy excess, high added fructose intake, ectopic fat. Fat at the wrong place. When you have fat in the liver, it is toxic to the liver and it is toxic elsewhere. So that's why you get coronary artery disease and changes in the gut leading to gut dysbiosis, probably due to fast food epidemic, and all these in genetically susceptible people. So what are the non-pharmacological interventions that you have to think of? These are the four main non-pharmacological interventions, and this is the mainstay in the treatment. Weight reduction above 5%, that's 7 to 10%. Calorie deficit, you have to be very familiar with these words. High vegetable, whole grains, fruits and fiber, and exercise. So this is the weight loss pyramid in this landmark study by Villa Gomez 5 years ago, which clearly shows that weight loss of more than 10% is going to reverse fibrosis in these people with progressive NAFLD. Mind you, these people have not reached the stage of cirrhosis, and the fibrosis can be reversed with loss of weight. Even if you lose more than 5% weight loss, it's going to lead to resolution of NASH. But unfortunately, only 30%, even under strictest of guiding, they can achieve only 30% of the patients achieved weight loss of more than 5%. This is one of the main issues in reducing the weight. So why so difficult to lose weight? So it is because obesity is a complex neuropsychological disease. Calorie reduction will lead to energy conservation, and if they start eating normally after a period of energy conservation, you can gain weight, and most will regain the lost weight, which is called weight recidivism. So the diet should be a low fat, low calorie at the same time, low refined sugar, no added fructose, low fast food, and the typical Mediterranean type of diet. I think you have to be very familiar with this, the principles of the Mediterranean diet, where they take, fruits, grains, and other things every day when compared to meats and sweets only on occasions like a party, so these are for everyday intake, and fish maybe or poultry twice a week, but very little sweets and meat. So this is the Mediterranean diet which is recommended in NAFLD. Then how fructose causes a fatty liver? They lead to de novo lipogenesis. It's like alcohol, very toxic to the liver. And if you visit the supermarket, all food stuff will contain fructose without your knowledge. And if you buy them and bring them home and drink them, like soft drinks, cordials, colas, then you will end up with getting fructose. And fructose is so bad to the liver, it's like taking alcohol. So last year, the Journal of Hepatology, the American journal, put out this poster saying childhood fructoholism and fructoholic liver disease. So fructose intake in childhood can addict the child to eating more and more fructose, that's sweet, and which can lead to fructoholic liver disease. And probably we are seeing an epidemic of fructoholic liver disease nowadays. So what about exercise? Beneficial in a study involving 169,000 patients. So moderate to vigorous exercise, more than 10 minutes, 5 times a week, prevents the development of fatty liver and resolution of the existing fatty liver. So you should continue exercise even if you don't lose weight. So continue a diet, continue exercise even if you do not lose weight. So after this study, the Journal of Hepatology, the #1 journal in the hepatology, gave this editorial: exercise in NAFLD, just do it. So this is how American cartoonist Randy Glassbergen saw this. what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day. Very appropriate. I think I like that cartoon. What about alcohol? Uh, I don't think you can consume alcohol if you have fatty liver because the disease mechanisms are same and it's going to aggravate your uh, disease. So what is lean NAFLD? Lean NAFLD is seen in patients who have normal BMI. So if your BMI is 23 and you still got NAFLD, it is lean NAFLD. This is probably genetics and major changes in the gut microbiome playing a role here. And lean NAFLD is also progressive and may carry a worse prognosis because of the genetics and the gut microbiome involved in this. And the same treatment options are applicable like exercise and dietary manipulation and some degree of weight loss. We can't ask them to lose 10% of their weight because they are already lean. So what are the pharmacological therapies available for progressive NAFLD? Vitamin E was shown to be beneficial in PREVENT's trial, and obeticholic acid was shown to be beneficial in the Regenerate trial, which is a phase 3 trial. And unfortunately, still these drugs have not been approved by the FDA. So because of that, they are still not in any of the guidelines, that is American, European, or Asia Pacific guidelines for the treatment of fatty liver disease. So if you are using them, we have to use them off-label. What is off-label treatment? Off-label treatment is when we use a drug which is not approved for a certain indication. So is it a crime to use them off-label? Absolutely not, because 20% of prescriptions even in America are off-label. So even in America, they use vitamin E and these drugs for people with progressive NAFLD on case-by-case basis. So this is the person, famous hepatologist, presenting the results of this Regenerate study. This is on obeticholic acid and very clearly beneficial, and because the pharmaceutical industry was so keen to get out this study, after 2 years they made an interim analysis and presented the data, and then they wanted approval from the FDA, but unfortunately last week FDA rejected the application for obeticholic acid. So as of today, there is no FDA approved drug for progressive NAFLD. So what about the statins? One thing I want to ask you is not to stop statins in these people if they just because the ALT is high, because a lot of these patients with fatty liver disease have other indications for commencing a statin. If they are already on a statin, if you want to start them on a statin, please go ahead with the statin because it's going to help the liver indirectly, and statins are safe in patients with fatty liver disease. You don't even have to test their liver functions. You test their liver functions only if they become symptomatic, presented with symptoms like fever or vomiting. So when do you want, as physicians, when do you need to refer them to the gastroenterologist, and that is if the diagnosis is uncertain, and also if you suspect the patient has progressive NAFLD, to initiate treatment. Summarize my first part of the talk, dear ladies and gentlemen. I'm talking about progressive NAFLD before they reach the stage of cirrhosis. So progressive NAFLD is mostly food related. Gut microbiome and genetics plays a major role. Fibrosis stage predicts survival and liver mortality. FIB4 score and FibroScan are reliable predictors of advanced fibrosis, not the AST/ALT levels. Lifestyle modification is the key, and 10% weight reduction reverses fibrosis, but unfortunately, few can achieve it. But still, please go ahead with your lifestyle modifications, even if you do not achieve weight loss. Pharmacological breakthrough is expected because there are more than 100 randomized control trials in progress, because if some drug gets approval, the company is going to be billionaire. So still, but there is no drug approved for the use. Statins have a role to play, but unfortunately, people are scared of statins. And please do not stop statins if they are already on. Please do start statin if they have indications for statin to be started, and I'm sure most of them will have an indication, and that's going to help the liver indirectly. So I'm going to the second part of the talk, that is what happens when they go into cirrhosis. So I'm talking about early cirrhosis with a LSM of 13, 14, 15, 16 stage before they start decompensating. So I'm going to start with another patient, my dear friend patient, who is 4 years ago. He accidentally detected to have 52-year-old male doctor who was accidentally detected to have macroscopic cirrhosis at laparoscopy for GB calculi. He was totally asymptomatic. He has had mild elevation of SGPT in the past, but attributed it to simple fatty liver. Workup for etiology didn't show positive findings, and he did not have varices. His mother had died of cryptogenic cirrhosis at the age of 65. So naturally, being a friend, he got scared and bombarded me with these questions. How long I am going to live? When will I need the transplant? How can I be suitable candidate for liver transplant? Is there any drug or any other measure to delay progression? My mom had it. Will my child get it? He was very concerned about that. Can we prevent cirrhosis in the child? I'm going to answer all these questions tonight. So we have to be familiar with new staging of the liver cirrhosis. I'm sure you are aware of decompensated cirrhosis. That's when you have all the symptoms of cirrhosis like edema, jaundice, ascites, bleeding manifestations, and so on. We have to go through stages 1 and 2 before reaching this stage. Stages 1 and 2 last for many, many years, maybe 10, 15 years. And stage 1, absolutely asymptomatic, no varices, no ascites, and like my friend doctor, the patient would not know that they have cirrhosis. So what is the life expectancy? If you have stage 1, no varices, they are expected to live for 10, 20 years. But unfortunately, if they develop something like viral hepatitis, or they are given a hepatotoxic drug, or if they develop a hepatocellular carcinoma, they can unexpectedly die. Stage 3, when they develop ascites, which is a watershed mark, ascites development makes you kind of live only for about 3 to 4 years. When you need regular paracentesis, your life expectancy is drastically reduced to about 6 months. So, can we delay progression? That is the main idea of my talk today. This should be your objective. Why? Because transplantation is not an option for all patients for cirrhosis, because the cost 10 million even to the government, organ shortage, we rarely have good organs for transplantation. You need expertise. You need a super surgeon and super anesthetist. We don't have many. And candidate is not suitable most of the time. They are older, they have heart disease, they have kidney disease, and they are not suitable for transplantation. And even in the developed countries, less than 25% of the patients with decompensated liver disease receive a liver transplant. So what's the new concept of managing cirrhosis? This is by Late Professor Andy Burrows, one of the modern greats of hepatology, who was editing the Sheila Sherlock textbook of medicine, he said just before his death, wrote in the Lancet, the new concept in management of patients with cirrhosis should be prevention and early intervention to stabilize disease progression and to avoid or delay clinical decompensation and the need for liver transplantation. The challenge in the 21st century is to prevent the need for liver transplantation and not liver transplantation in as many patients with cirrhosis as possible. So try and delay decompensation and try and prevent transplantation. How can we do that? Can this patient, my friend, die unexpectedly from a liver related cause? Yes. One is liver cancer, other one is acute on chronic liver failure following an assault on the liver like hepatitis A, dengue, drug induced or Ayurveda medicine induced hepatitis. So objective is to prevent this. Then he can also die from an liver unrelated cause. So what specific measures have been shown to be beneficial in delay to treat the underlying cause like hepatitis B or C, you treat them. If you have alcoholic cirrhosis, stop alcohol intake. Then surveillance for hepatocellular carcinoma. I'm going to come into this topic big time. Then vaccination, for especially for hepatitis A and B. And because of the improvements in the health system and the hygiene, more than 50% of our adult patients with cirrhosis are non-immune for hepatitis A. So if they develop hepatitis A, that's going to be the end. So they need vaccinations for hepatitis A and B and the surveillance for esophageal varices. So can we treat the cause with established early cirrhosis in NAFLD cirrhosis? We can treat hepatitis B when they have cirrhosis. We can treat hepatitis C. We can treat autoimmune with steroids. We can treat Wilson's. We can treat hemochromatosis. We can treat alcoholic liver disease by abstinence. Can we treat NAFLD early cirrhosis? We don't have RCTs, randomized control trials, to tell you that. But lifestyle modifications and vitamin E and obeticholic acid should have some role to play. So make sure lifestyle modifications are in place, and there is a randomized control trial called reverse trial with obeticholic acid to see whether this drug is working in early cirrhosis due to NAFLD. So what general measures? There are a lot of general measures like losing weight by about 10%, avoiding non-hepatotoxins like non-steroidal anti-inflammatory drugs, avoiding alcohol altogether, avoiding smoking because smoking leads to fibrosis, and increasing coffee intake. Coffee is known to retard the progression of fibrosis both in fatty liver and in cirrhosis. And nutrition, the new latest topic interested to hepatologists regarding delay in the progression. So get a nutritionist involved in dealing with the nutrition of the cirrhosis patient, and exercise. I'll take one by one and enlighten you on these. So non-specific treatment, alcohol abstinence. This is absolutely necessary because alcohol intake increases the risk of hepatocellular carcinoma in all patients with cirrhosis, though they can't be drinking at all. Smoking is associated with more severe fibrosis. They should be stopping smoking as well. So there's a lot of interest on coffee, and coffee is very well known to retard the progression of fibrosis, and the mechanisms are being identified. So you can advise them to take at least 2 cups of strong coffee for the day. Then sarcopenia, that is loss of muscle mass attributed to poor life expectancy. And we have to deal with sarcopenia, and that is skeletal muscle loss due to variety of reasons, including hypermetabolic state, zinc deficiency, loss of appetite, physical inactivity and obesity, which lead to sarcopenia, skeletal muscle loss seen in cirrhosis, which is uh, uh, attributed to poor outcome. So there is a lot of interest on sarcopenia and how to deal with sarcopenia in liver cirrhosis. So one is to exercise and some kind of an exercise regime from the onset of cirrhosis till they decompensate, so that they have good muscle mass remaining when they reach the end stage. And also a lot of interest on the nutrition, and the ESA, the European Association, put out this guideline on the nutrition. And what the summary is that nutritional assessment by a nutritionist in all cirrhosis patients, including their muscle strength, and they can eat anything maybe except alcohol, and normal calories, and maybe normal or high quality proteins, and even more than what should be taken in a normal person. That's one of those paradigm shifts. Now we asked them to take a lot of proteins, and it was quite the opposite 20 years ago. So if obese, 10% of weight loss recommended with 500 to 800 kilocalorie deficit while maintaining the protein intake. Any pharmacological treatment with survival benefit? Yes. Surprisingly, another paradigm shift here, statins, metformin. Those were not allowed 10 years ago. In fact, they thought that they are detrimental in patients with cirrhosis. And the beta blockers and the new antibiotic, non-absorbable antibiotic rifaximin. So statins, it has a lot of the pleiotropic actions of statins. It has a lot of benefits in reducing the fibrosis, reducing inflammation, reducing angiogenesis, preventing the formation of hepatocellular carcinoma. So statins may be even a wonder drug in the future for cirrhosis, theoretically beneficial, animal studies beneficial, observational studies very beneficial, small randomized control trials beneficial, and larger randomized controls trials are pending. And we have a lot of hopes that statins are going to be of great value in patients with cirrhosis. So all the big hepatology journals are coming up with articles praising statins, and looks as if these are all big shots in hepatology nowadays, and they are probably predicting that it's probably going to be the first drug that is going to recommended in the future for the retardation of progression of cirrhosis, which is absolutely valuable for these patients, because as I told you before, transplantation is an option only for very few selected patients world over. So then the next topic I'm going to talk is the hepatocellular carcinoma. This is a large hepatocellular carcinoma. So I'm going to discuss another patient, my final patient tonight, a 55-year-old man followed up by an endocrinologist for type 2 diabetes mellitus for many years, complained of loss of weight for 6 months. The endocrinologist attributed it to metformin. The patient had a family history of cirrhosis. The patient's siblings, including 2 medical consultants, wanted a second opinion, and he was diagnosed to have an inoperable hepatocellular carcinoma, and he succumbed to illness 2 months later. So it was not a pleasant situation to be in for this endocrinologist. Could we have avoided this? My answer is yes, we should. Screening diabetics for NAFLD. So I think diabetics are being screened for everything under the sun from head to toe without getting screened for fatty liver disease. Then if you screen them for fatty liver disease, they should undergo these fibrosis markers every 2 to 3 years so that they could detect cirrhosis. And this patient, 55 years and long-standing diabetic, had all the risk factors for the development of cirrhosis, fibrosis and cirrhosis. He should have had FIB4 score done many years ago. And if they have advanced fibrosis and cirrhosis, they should undergo a surveillance for hepatocellular carcinoma for 6 months. If the protocol was in place, we could have diagnosed this patient early and could have initiated curative treatment for his hepatocellular carcinoma. So why identify a hepatocellular carcinoma early? It is the most important cause of death in cirrhosis. Even patients with early fibrosis and cirrhosis are at risk, and surveillance scanning with ultrasound scan and alpha fetoproteins indicated in all patients with cirrhosis every 6 months. And a small hepatocellular carcinoma is treatable. So if you are looking after patients with cirrhosis, it's unfair for you to not to screen them every 6 months, not to do the surveillance for varices every 6 months to 1 year. So if you are treating these patients, it is mandatory for you to know the latest developments in the field and carry them out so that these patients are benefited by your knowledge. So what the internist should know, the physician should know about hepatocellular carcinoma a lot. Hepatocellular carcinoma occurs most of the time in patients with cirrhosis. You would rarely see a hepatocellular carcinoma outside a patient with cirrhosis, and very treatable if we found if it is smaller than 5 centimeters. And surveillance is the key, and by experienced radiologists in the field. Treatment options and prognosis depends on the stage of liver function. So if you have child A, it can be treated, and if child C, there is nothing except liver transplantation. And the diagnosis is radiological, that is contrast CT or dynamic MRI, not the liver biopsy. And it is the medical gastroenterologist who is coordinating the management, so don't refer them to Maharagama or surgeons. If you have a hepatocellular carcinoma, please refer them to the medical gastroenterologist. And there is absolutely no place for systemic chemotherapy in these patients. So this is what you see, this whitish area is a contrast CT in the arterial phase. You see the aorta here, you see enhancement of the lesion. So arterial enhancement followed by venous washout. The venous phase and you black area contrast that washed off from the tumor. So arterial enhancement and venous washout is diagnostic of hepatocellular carcinoma in a cirrhotic liver. So to whom to refer to? Medical gastroenterologist. Liver transplant, and I'm going to touch on liver transplantation during my final few slides. And the physician should know the indications for transplant, decompensation. When a patient decompensate, if there is a chance of getting transplant, please refer them to the gastroenterologist. What are the indications? An episode of hepatic encephalopathy, episode of variceal bleeding, resistant ascites, spontaneous bacterial peritonitis, hepatorenal syndrome, and a hepatocellular carcinoma. If a patient has any of these, please think of referring for liver transplantation. And selection a candidate for transplantation is pretty difficult. Age, if they are old, maybe more than 60, 70, they are not candidates. Health literacy. So if they do not understand what transplant is, if they are going to stop tacrolimus intake when they feel that they are all right, or they don't have social support, they are not candidates for transplantation. Surgery is difficult. You need a super surgeon and a super anesthetist. We don't find them often, but outcome is brilliant. They are not on long-term steroid like renal transplant. See the difference in this child on the left-hand side and the child on the right-hand side. Even for an adult, the change of the picture is going to be the same. So liver transplantation for fatty liver associated cirrhosis, unfortunately, they are not good transplant candidates because of the comorbidities. They are obese, they have long-standing diabetes, they have heart disease, they have kidney disease. So they are not very good liver transplant candidates. So when to refer to the gastroenterologist, these patients with cirrhosis, depending on the accessibility. So if you have a gastroenterologist next door, you can refer them at the beginning even. But if you say 100 kilometers away from a gastroenterologist, but if you are still uncertain that this is fatty liver, please refer them, because we do not want to miss a treatable etiology like autoimmune hepatitis. Then for variceal surveillance, you need a gastroenterologist, because it's better than referring them to a general surgeon, because they will give you advice on the treatment options like when to start beta blockers and so on. If they have a liver space occupying lesion like maybe a hepatocellular carcinoma, then you have to refer them to the gastroenterologist, because SOL in a cirrhotic liver is a hepatocellular carcinoma unless proven otherwise. And if there is a thrombus in the portal vein, they can be very bad bleeders when they start bleeding, and you need a gastroenterologist to attend to them. And when they decompensate, again to treat, again to take treatment and transplant decisions, you may need a gastroenterologist. So regarding my friend, what I am going to do, so how we are going to manage this very early cirrhosis patient with cryptogenic cirrhosis, right? So this is cryptogenic. In fact, this is NASH cirrhosis. So when we can't find the cause, we call it cryptogenic, but very likely to be NASH cirrhosis. So he has to undergo surveillance for hepatocellular carcinoma every 6 months and endoscopy every 2 years, because they have no varices. Vaccinations for at least hepatitis A and B, and avoid hepatitis E risk. Hepatitis E is very common in our neighboring countries, and if you go outside Sri Lanka, they should not be taking food from unhygienic places. Metformin is indicated if the patient is a diabetic, because metformin reduces the risk of hepatocellular carcinoma. So this is the best drug to be using if he's a diabetic. Statin if he has other indications like hyperlipidemia and diabetes and so on. The lifestyle modifications like correct BMI, taking coffee, stopping smoking if he's a smoker, stopping alcohol altogether, and the correct nutrition and exercise to avoid sarcopenia at the end. That improves survival and the prognosis following liver transplantation. This is cryptogenic cirrhosis. This is most likely NASH cirrhosis, and look after the cardiovascular risk, because we need the coronaries and the kidneys in good shape for the transplant. So he is asymptomatic. So no beta blockers, no diuretics, no PPI, no lactulose. So he does not need any medication. So natural cause, he will need the transplant in about 10 to 15 years. So I have to answer the questions by him. So how long I am going to live? Roughly 10 to 15 years. When will I need the transplant? 10 to 15 years. If there is any drug or any other measure to delay progression, yes, I have told him everything that I told you tonight. Will my child get it? Very likely. Mother had it, he had it, so very likely that child is going to get it. Can we prevent cirrhosis in the child? Probably yes, in the future with all the advances in the field. So to summarize, ladies and gentlemen, progressive NAFLD will end up with cirrhosis and hepatocellular carcinoma. Fortunately, then it is only about 10% of the total fatty liver population. They are poor transplant candidates. Decompensation could be effectively delayed by interventions. No recommended pharmacological intervention available for reversal of fibrosis. And of the drugs in the pipeline, statin appears to be most promising. So even in a cirrhotic patient, if you do see them on statins, please do not stop them. They are not going to do any harm. They are probably going to be beneficial. And even in a patient with stable cirrhosis, if you see the indication for starting a statin like long-standing diabetes or elevated LDL or strong family history of MI, please go ahead and do start the statin, because it's going to help the liver indirectly. And correct nutritional interventions, because we don't want to prevent sarcopenia at then. So exercise regimes. So get hold of nutritionist and advise on exercise and nutrition very carefully and take care of the other coexisting illnesses so that they can have better life expectancy and better survival after the liver transplantation. Thank you very much for kind attention.
Thank you, Professor Anuradha, for this elaborative lecture. I suppose you would be happy to answer a few questions. There are plenty of questions that have been sent by the audience. So one such is, now we do see a lot of progressive NAFLD, but do we diagnose, now we see a lot of fatty livers on routine ultrasounds. So now, how do we diagnose progressive NAFLD? Is it by symptoms? Is it biochemical, or is it radiological?
Well, Krishantha. So what we do commonly is to do ultrasound scan and transaminases. Now, those two investigations will not tell you whether this is progressive or progressive NAFLD or non-progressive. So just can't diagnose progressive NAFLD by ultrasound scan or by transaminases. You have to either do a fibroscan or the FIB4 score. FIB4 score will include the transaminases, the platelet count, and the age. So most important test for us in Sri Lanka would be the FIB4 score. I think all of us should be familiar with the FIB4 score. And if we get a patient who has all the high risk factors like middle age, family history of cirrhosis, all the features of metabolic syndrome coming to you around 50 with a fatty liver on ultrasound scan, please do the FIB4 score, because we don't have facilities to do fibroscan for all patients in our country. There are maybe 2 or 3 fibroscanners for the entire country. So FIB4 score is the most appropriate way of diagnosing, and all these NAFLD patients should have the FIB4 score every 2-3 years. And if you diagnose progressive NAFLD, please do refer them to the gastroenterologist so that they can initiate the treatment after fibroscan or a biopsy.
Yeah, there's another question, Professor Anuradha. Now, how often should you repeat the FIB4 score?
Yeah, if they do not have NAFLD, the international guidelines recommend it to be repeated every 2 to 3 years. So in between, you can refer them back to the physician and ask them to start them on lifestyle modifications, the treatment of risk factors like diabetes and hyperlipidemia, the dietary advices that I gave you. And usually, Krishantha, these measures will normalize the transaminase levels. If the transaminase levels are not normalizing, then you have to go behind another cause like hepatitis screening and other things. But if usually these measures will normalize the transaminases, and then you get them back after 2 to 3 years, and the physician himself can do it. The just FIB4 score is a very simple score, and the app is freely downloaded in the smartphone.
Yeah, now other thing, there is another question, Professor Anuradha. Now, there are certain illnesses other than NAFLD that can give a temporary rise of transaminases. So in such instance, how long should we wait to assess the FIB4 score?
At least a month. So even with normal viral infections, say dengue, transaminases go up. Even COVID goes up. So any upper respiratory traction, it goes up. So so the issue is that say if you have a ultrasound scan proven fatty liver, the transaminase is high, if it is not coming down, if you suspect infection, the full blood count and other symptoms will tell you that he has had the upper respiratory tract infection or so on. So then wait for about a month and recheck it. And if it is high, then you consider it to be persistently transaminases, and then you have to go behind for a cause.
Yeah, I think the A lot of people are interested in this statin talk also. Now there's a question now, is there a cutoff transaminase value that you might not now say if it is a 5 times normal, so should you still consider giving statins in a patient with NAFLD with the
Yes,
dyslipidemia as well?
I will tell you. Now, say if the liver enzymes are 5 times upper than normal, say if you take normal upper limit as 40, if the liver enzyme transaminase level is 200, then you have to positively diagnose this as NAFLD, right? So if you exclude all other hepatitis B, alcoholism, hepatitis C, Wilson's and everything, autoimmune, you exclude all other diseases, right? So then what you can do is you initiate all the lifestyle modifications, and if the enzymes come down within next 2-3 months, you positively diagnose NASH without a biopsy. After exclusion of all the other liver diseases, even after initiating the lifestyle modifications, if they do not come down at 3 months, you biopsy them. And if the biopsy says it is NAFLD, then even with the transamin level of 200, you still start the statin if it is indicated for the illness that is going to get it. Like say diabetes with hyperlipidemia, you get it, provided that liver enzyme elevation is due to NAFLD. Did you get my point, Krishantha?
Yes, that's right.
Okay.
I think one final question, Professor Anuradha. Now, I think you are heavily involved in this liver transplant unit at Praga, but there's another question now. Are you happy with the progress of the current liver transplant system in our country?
No, absolutely not, because there are a lot of issues, facility issues, organ donation, and the quality of organs. Unfortunately, Krishantha, when we are offered, it's very strange. It's very different from kidneys. If a patient is brain dead, you can naturally take both kidneys. So you have 2 kidneys, but the liver has to be in good condition for transplantation. Unfortunately, most of our people, I told you in my talk that 60-70% of our people have fatty liver. So those fatty livers are not good for transplantation, because when when we give them these fatty livers, they do not perform well. So unfortunately, there's no dialysis system available. So if you try and transplant them, and if the new liver is not going to work, you are going to die. So they are at risk of dying. So we do not put in these fatty livers. So very few livers are available for transplantation. So not happy at all, but maybe for the past 10 years we have done about 50 transplants, but most of them have worked out nicely. But say when you see these patients who survive, they are performing brilliantly because they are no longer on steroids like kidney patients. So it's a difficult operation, very difficult to find candidates, very difficult to find organs because of this fatty liver issue, and not happy, but unfortunately, but still we do 2-3 transplants a year, and I think we have to move forward and do it. But if we don't do it, who is going to do it?
Okay, Professor Anuradha, in the interest of time, I suppose I would like to conclude this session, and I would really thank you for the contribution as a physician that you have done to this the patients with liver disease. And I also would like to thank you for enlightening the importance of surveillance of progressive NAFLD and the importance of prevention, and also the current concept on hepatocellular carcinoma and liver transplantation. I would also like to thank Professor Tilak Jayalath and the EXCO of SLSIM for the continuous encouragement to the membership to engage in CME activities. And also my gratitude goes to Mr. Anton Thailand of Luminary Learning Solutions for facilitating the technology for this webinar. And also to Mr. Prasad Mentis, the country head, and Mr. Wasim Wadud, the brand manager of Dr. Reddy's Laboratories, for sponsoring the event. And to all of you for taking part in this live webinar and sending your interactive questions. Wishing you a pleasant evening and hoping to meet you in the next webinar organized by SLC.
Thank you.